Hi, Mohammed Al-Mala here with case 4 of our small pupil cataract case series. So let's start this case here. We'll get started. This is a case actually from last year, 2024. And we can see that we have a moderately sized pupil between 4 and 5 millimeters here in size. We are injecting preservative-free lidocaine followed by preservative-free epinephrine. And the epinephrine really doesn't dilate the pupil very much. It just helps to keep it from coming down, helps to prevent the pupil from coming down. And then shortly here, we're going to inject Viscode into the anterior chamber. And we'll get some Viscomydriasis or Viscodilation. So this is case 4 of a series I'm putting together for how to manage small pupils. I'm going to put a link for the playlist, which features all these cases. I also have some other videos on managing small pupils. I think it's important before attempting to manage small pupil cases without using a pupillary expansion device to be comfortable using pupillary expansion devices, and especially iris hooks. So if at any point in time you feel like you're in trouble or you're having a difficult time with visualization, you're able to put the hooks in and rescue your case. So here we're doing the capsulorhexis. I have 0.12 forceps stabilizing the globe. I use the 0.12 forceps with the paracentesis. Whatever method you use to stabilize the globe, I think it is nice rather than just relying on the patient being still. It gives you a lot of confidence when you do your case to know that the globe is stabilized. And here we're doing the capsulorhexis. You see, we're not afraid to go right up to the edge of the pupil, and we can follow the pupillary edge here, or if the pupil is smaller, we can actually go underneath the pupillary margin to complete the continuous curvilinear capsulorhexis. Okay, that's done. Next step, of course, is hydrodissection. Whenever, very important when this pupil is small, to watch out for iris prolapse. So we want to be pushing on the posterior lip of the wound to make sure that the anterior chamber decompresses and the iris is not prolapsed. Not too much of an issue with iris prolapse here. And then once we've achieved hydrodissection, I just do one fluid wave. I try and achieve a cortical cleaving hydrodissection. We go in with phacoemulsification. Here is the phaco probe and the Nagahara chopper. I go ahead and start out in quadrant removal mode. I'm doing a phaco chop technique, so I go ahead and just bury my tip into the nucleus and phaco, and then we use our second hand here to do a horizontal chop maneuver and bring that instrument to the phaco handpiece tip. You can see just with that one single fluid wave, we got a good rotation here. The lens rotated by itself as I was doing the chop. We've chopped the first heminucleus using the same maneuver. And here you can go ahead and start taking pieces if you like, or you can rotate and remove and chop the second heminucleus as well, and then start removing. So it looks like in this case, for whatever reason, I decided to go ahead and remove the first quadrant. And we're using the Alcon Centurion here. We are using intelligent phaco, so most of this is torsional, and then it kicks in longitudinal phaco as well. So I've gone now in the last few months to relying more on longitudinal phaco with this machine, but whatever settings you like and you feel are most efficient for you, and it's number one, safest in your hands, and number two, most efficient are the settings that you should use. So we've removed 2 of the quarters here. We removed half the nucleus. We still have half the nucleus left, and it is not chopped. It's still intact. Good rotation here with just that one continuous fluid wave that we got with the hydrodissection. And looks like I'm going to chop here. So we chop that second heminucleus, kind of a vertical chop there, but that's fine. I think with denser nuclei, it's easier to do a vertical chop, even though this is not a sharp tipped chopper. You're still able to do some vertical chop with this chopper. And then we go ahead and remove the third quarter. You can see that we're making good progress here. Even though the pupil is small, we're able to work in the center of the pupil and really have good visualization of what we're doing. If you're doing phaco chop or horizontal chop, You really don't need that great of a visualization. It actually lends itself nicely to doing small pupil cases. I think it's more difficult to do small pupil cases without a pupillary expansion device if you are doing divide and conquer. So we can see we still got some cortical material here, and our hydrodissection did not achieve complete cortical cleaving, so we still have a layer of cortex here that we need to remove. It is harder sometimes to achieve cortical cleaving hydrodissection when the pupil is small because you can't actually visualize yourself tenting up the anterior capsule. You can't visualize that triangle sign. So we're going in with IA, and we are removing the cortical material. Really nothing special here. You want to be careful about not snagging the iris. You want to make sure you're below the capsular rim or away from the iris margin. It's not uncommon or unusual to snag the iris here with your IA probe. If that happens, you just stop irrigating, reflux, and release the iris. But nonetheless, it's better if you're able to avoid doing that because it will make the pupil come down even more. So we've removed the cortex here. We still have some remnants. I'll probably use a terry squeegee here to capsule polish. And you can see I zoom in so I can get a better view of those little remnants there that are on the posterior capsular surface. And I use a terry squeegee which is a cannula with a silicone sleeve to polish that posterior capsule and just to remove any of those little material there that are on the posterior capsule. So once we do that, we're going to inject ProVisc, cohesive viscoelastic, into the capsular bag. We zoom out again for that part of the procedure. And we fill the capsular bag and the anterior chamber with viscoelastic, and then comes our lens. Also be careful here not to get iris prolapse whenever you inject your viscoelastic. Sometimes you can get iris prolapse during this part of the procedure. We deliver a single piece hydrophobic acrylic IOL into the capsular bag. And then I go ahead and position that with the IA handpiece directly. I do not initiate irrigation until the haptics start to unfold because the irrigation fluid is cold and it's going to make it take longer for the haptics to unfold. So once the haptics start unfolding, then I go ahead and turn on irrigation and I irrigate and aspirate out that viscoelastic material. So if the optic is about 6 millimeters in size, we can see our pupil here is probably about 4.5 millimeters. This is a Charvel or a second instrument that I use to retract the iris to make sure we're not leaving any cortical fragments or cortical remnants or cortex behind. And that looks pretty good. And then we are done with this case. We'll just go ahead and hydrate the wounds. We'll hydrate the main incision first. I'll hydrate the roof of the main incision first. And we're not really reforming the anterior chamber when we're at the main incision. At the paracentesis is where I reform the anterior chamber. And we're going to the right and left of the wound here. We are looking, just making sure we're not leaving any nuclear fragments behind. Since we've gone into the main wound again, we're probably going to have to irrigate that main wound again, or maybe not. We may have already achieved a watertight closure. So I always check with Wexel sponges. I always check my incisions, make sure they're nice and watertight. And looks like we got some leakage there at the paracentesis, and I'll continue to work to make sure that we have a watertight closure. So that's handling a small pupil without a pupillary expansion device. It's not the smallest pupil, but using that phaco-chop technique, you really are able to do that without requiring a pupil expansion device. Questions, comments, please leave them below and look for the next case in this series. Thank you for your attention.